through the childhood and infantile period, I mean, and then the childhood. Also, I tried to make it very simple in form of case scenarios that is commonly seen in the emergency department because it is really kind of very catastrophic for the parents to present child who have loss of consciousness or deterioration in the level of consciousness. And also I tried also to include some images, and also in neurology we can't practice without brain CT scan and brain MRIs, and I would show you as well the commonest findings in patients with encephalopathy. And of course, we will summarize the management approach for any patient with encephalopathy, and we will finish with take-home messages. By definition, encephalopathy is a clinical state characterized by alteration of consciousness, behavior, and or cognition. And to make the definition simple, you can just define it as a global brain dysfunction.
Ali,
on the other hand, yes.
Can you share your screen?
Oh, it's not shared.
Yeah, it's not shared. Sorry, Ali.
Okay, that is fine.
Slide, yeah.
Can you see the slide now?
Yes. Press F5. F5.
Okay.
Yeah, that's fine. Okay.
So again, these are the objectives. Just you can go through it, and moving on to the definition. As I said, encephalopathy is a clinical state that characterized by alteration of consciousness, behavior, and or cognition, or if you like, you can say just is a global brain dysfunction. On the other hand, encephalitis, one of the most common etiologies for encephalopathy. As you can see, most of our patients with encephalitis, they present in encephalopathic state. And encephalitis is referred to specifically a brain inflammation or inflammation of the brain parenchyma, and usually associated with fever, with evidence of cerebrospinal fluid inflammations that usually in form of pleocytosis, high protein in the CSF, and possible positive culture. And sometimes we can see some specific neuroimaging findings in patients with encephalitis. Specifically when you talk to herpes simplex encephalitis in children, you might find some signals in the temporal lobe, but also you can find the abnormalities elsewhere in the brain. But again, normal brain image will not exclude the diagnosis of encephalitis. The clinical presentation of encephalopathy in general is very wide and variable, starting from lethargy and drowsiness, and this is at the beginning of the spectrum, and some cases they are at the end of the spectrum. They present sometimes with agitation, irritability, and confusion. And among adults, you can hear about different terms like stuporose and kind of comatose and that terms, and all of these are kinds of encephalopathic state. Also in children, we do see the patients with encephalopathy, they might present with seizures, and specifically status epilepticus. And also the classical example is subclinical status, not necessarily for the patient with epilepsy to present with motor seizure. Sometimes they might present with just confusional state, and we call it subclinical seizure. And also can present with visual disturbances, speech abnormalities, dysarthria, or even aphasia. And drooling, one of the cardinal signs, especially in severely encephalopathic patients, motor weakness, starting from monoparesis, hemiparesis, or even quadriparesis, sensory and autonomic dysfunctions. When you talk to the sensory and autonomic dysfunction, I mean, it could be kind of loss of bladder control, or it could be fluctuation in the vital signs especially if there is involvement of the brainstem or if there is any organic pathology in the brain. Patients with encephalopathy, they might also present with movement disorder, either hyperkinetic movement or hypokinetic movement. Hyperkinetic movement could be kind of dystonia, ataxia, tremors, and hypokinetic movement, they might present with catatonia, for example, or dyskinesia. With catatonia or Parkinsonian features or whatever. In general, encephalopathy in pediatrics patients is associated with significant mortality and long-term morbidities among survivors, especially if the treatment is not optimum and is not an immediate intervention. These are 3 points are very important to be considered in our approach for any patient with encephalopathy. Careful attention to the onset, duration, and progression of the symptoms is very important. And just example for this, if the patient presents with acute symptoms within like less than 30 minutes, you have to think about the specific etiologies, and then you have the management, it will be different and it will be directed. Any rapid deterioration.
Yes? Ali, please, your slide is not moving. I don't know what's the problem. I mean, okay. Yeah, now good.
Yeah, and the second point is that to have to be addressed is there is any rapid deterioration of Glasgow Coma scale in a patient who present with mild encephalopathy and rapidly deteriorated to severe encephalopathy. You have to think of raised intracranial pressure, and as well focus examination. Focus examination is very important, and definitely any examination should be guided with granular history, good history. It also is very important in our approach. Just to make it simple, as I said, I divided the etiologies to different age groups, different age categories, from the neonatal period through the infantile period and then the childhood. Talking to the etiology in the neonatal period, neonatal encephalopathy usually could be resulted from hypoxic ischemic encephalopathy. And I think here this is related to the immediate postnatal period, and you have to check your Apgar score, which is a good indicator for evidence of hypoxic ischemic encephalopathy. And good postnatal setting, I think it helps in preventing such catastrophic conditions that might end with severe neurological problems. Neonatal sepsis, also one of the preventable etiologies, which is common in our setting in Sudan and in Africa in general. And I think prevention of sepsis and good treatment based on the cultures and the immediate interventions for treatment of neonatal sepsis also will help us save a lot of children from neurological complications. Bilirubin encephalopathy, also one of the commonest etiologies in a poor setting regions. And I think if you expecting patients who might develop or at high risk of developing bilirubin encephalopathy, like patients with rhesus incompatibility or ABO incompatibility or rhesus incompatibility, they has to be addressed and treated and observed post-delivery till we make sure that they are safe to be sent home. As I said, the first 3 conditions or the first 3 etiologies in the neonatal period are definitely preventable if we work hard and address them earlier. As you know, the bilirubin encephalopathy affects the basal ganglia and specifically the globus pallidi, and they have characteristic movement disorder. Usually they present with chorioacetoid cerebral palsy and impaired of upgaze. We call it upgaze palsy. Neonatal stroke and intraventricular hemorrhage, one of the very important etiology, has to be addressed in the neonatal period for the neonatal encephalopathy as a major etiology, and the intraventricular hemorrhage specifically is common among preterm babies. And as you know, that are different grade from grade 1 to grade 4, and the more the grade, the more the complications. And we can't move without talking about metabolic encephalopathy during the neonatal period, as not that much common causes, but we do see some patients with metabolic decompensations. And I would start with the treatable conditions first, as Dr. Abdullah, he's already talked about the pyridoxine-dependent seizures and folinic acid deficiency, and these are the treatable conditions, also has to be addressed earlier. And if you see a patient with recurrent seizure in the neonatal period, and the patient is encephalopathic, hypotonic, and lethargic, and is not that active, and you're expecting metabolic encephalopathy with seizures, you can provide the vitamins as supplement empirically, especially in our setting, just to make sure that you didn't miss a treatable condition. Urea cycle defect, this is characterized by hyperammonemia. It's a common cause of encephalopathy early in the neonatal period, and also has to be considered, and it is easy to check the ammonia, and also the importance of the neonatal screening. If we do have, also we will save a lot of brains. Non-ketotic hyperglycemia, Dr. Abdullah also highlighted on that, commonly present with recurrent seizure, hyperexcitable neonates, pair suppressions, and erratic neonates. And this is, we call them the end of the spectrum of the encephalopathy, the active encephalopathy, the irritability, and so on. And I think there are very important points here related to glycine encephalopathy. Usually they do have recurrent hiccups and erratic jerks and to stimulation. So when you find a baby with recurrent hiccups and highly excitable with exaggerated motor reflex, you have to consider that. And the EEG is useful, as I said. It showed pair suppression, and I'm going to show you what it looks like, just to consolidate your information on detection of the pair suppression on the EEG. Early onset epileptic encephalopathy and epilepsies in the early neonatal period, like Ohtahara syndrome in the past and currently called early infantile epileptic encephalopathy. And also there are a rare genetic and structural pre-malformations that has to be considered. To make the presentation is more fruitful, we can start to the practical scenarios, clinical scenarios for the neonatal encephalopathy. And this is a 2-day-old neonate seen in the NICU for recurrent seizures. This neonate was born at term via emergency cesarean section due to prolonged second stage of labor. And this is the usual scenario in our setting. Apgar score was found to be 5, 7, and 8, which is not bad, and the patient not required any resuscitation. The pairs weight of that infant was 2.8, and the head circumference is 33.5, which is within the normal limit. This baby required NG feeding because he is very lethargic and found he is not able to feed himself, and sugar and electrolytes were maintained, and he remained lethargic with poor tone and diminished primitive reflexes, and his examination did not reveal any dysmorphic features of note. And I think the approach of this infant is good, because the clinician starts with the basic things. He makes sure that the patient feeding is maintained even through the NG tube. That is fine, and also the sugar and electrolytes maintained. Also those are treatable causes for seizures, metabolic causes of seizures, and can be treated as bedside with the bedside test. But 3 hours later, post-delivery, noticed to have increased seizure frequency with in form of multifocal seizures, and for that reason, phenobarbital was initiated. Sepsis screening came negative. One of the commonest etiologies for the neonatal seizures and neonatal encephalopathy. Serum ammonia as well, very important to be checked, which is normal. There is no evidence of hyperammonemia, that is good. And the rest of the metabolic workup is bending. But the EEG of this neonate in the NICU during the continuous monitoring showed that there is evidence of pair suppression, and the pair suppression is indicate that this neonate is encephalopathic. Brain MRI, fortunately, day 3 reported to be normal, and there is no evidence of any hypoxic ischemic encephalopathy, and that was very clear from the Apgar score early in the history. And this is a very important slide for you. Don't be scared from the looking at the EEG. At least you have to identify the common abnormalities, and this is a classic pair suppression. As you see, there is activity here seen in the middle of this epoch, which is generalized epileptiform discharge, but thereafter immediately there is kind of flattening of the background, and this is easy to identify, I think, and every one of you can pick this up and decide further. And this is confirmed that this neonate is encephalopathic. So from that scenario, pair suppression in neonatal EEG indicate encephalopathy. Consider vitamin trials for any refractory neonatal seizure that did not respond to the first line, which is phenobarbital. Other vitamins also has to be considered, like pyridoxine, pyridoxal phosphate, folinic acid, and some people also add biotin and L-carnitine as a supplement that helps. Without any further kind of talk about the neonatal encephalopathy, we can move forward to infantile encephalopathy. And infantile encephalopathy, I think, is also common age for encephalopathy, and we do see a lot of patients during the infantile period come to the emergency with encephalopathy and alteration in the level of consciousness and brain dysfunction. And talking to the etiologist, febrile encephalopathy is the most common cause for infantile encephalopathy. And also in this group of patients with febrile encephalopathy, not because infants, they have high tendency for viral infections and viral prodromes and febrile seizures and so on. Febrile encephalopathy is very important. Also, epileptic encephalopathy is very important, as Dr. Abdullah already alluded that Dravet syndrome for any atypical prolonged febrile seizures has to be considered as a cause of encephalopathy in the early infantile period. Moving to the second common etiology for encephalopathy in infant, gastroenteritis with dehydration, which is common in Sudan in our setting, and usually present with electrolyte disturbance, specifically the sodium, either hypernatremic or hyponatremic dehydration is very important to be considered, because the very important electrolyte for us as a neurologist. All the electrolytes are normal, need to be normalized and important for us, but sodium is very crucial for us as a neurologist. Any hypo or hypernatremia can give you encephalopathy, can give you seizures, can give you a lot of things. And severe dehydration sometimes associated with venous sinus thrombosis, and this is also a common cause of encephalopathy among dehydrated children. Infantile epileptic spasm syndrome, this is a clinical diagnosis, and I'm sure every one of you can diagnose infantile epileptic spasm easily without any difficulties from Dr. Abdullah lecture. And characterized by seizure in cluster. We call it salam attack, flexion and extension, and it is very annoying for the children because it is associated with firing of the electricity in the brain. Sometimes the spasms look subtle, but inside it is really annoying. Encephalitis, meningitis, and encephalitis. For me, I would consider encephalitis more than meningitis in encephalopathic children. But again, even meningitis sometimes can present with encephalopathic features, and also is common. Glutaric aciduria is common among infants and is a common cause of infantile encephalopathy, and the scenario usually very clear. that your infant have background of developmental delay, and the head circumference is start to grow and crossing the centile up, and usually they present with macrocephaly, and usually the metabolic decompensation is triggered simply with just minor infections, and usually the parents brought such patient to the emergency with hypotonia and lethargy and poor feeding, and thereafter they tend to have kind of movement disorder and dystonia and even seizures sometimes. Non-accidental injury is very important etiology to be considered, and it is need high index of suspicion, and you have to think of that, especially if there is inconsistent history and clinical examination findings. There are many other causes for infantile encephalopathy, but I just address the common etiologies that probably commonly seen in the emergency. And this is hypserrhythmia. I think we shared the same slide. Dr. Abdullah, I think he put the same slide. And as you see, this is, and this type of EEG, I think the patients who have such EEG deserve to be encephalopathic, because look at the electricity of the brain, very chaotic, high amplitude, asynchronized, and it is usually associated with severe encephalopathy and sometimes neuroregression and developmental regression. And for the developmental regression in infantile spasm and hypserhythmia, you have to be very meticulous, and you have to be very careful taking the history and the developmental history, because some of those infants, they just lose their fixing and following, and they are not behave like before. And sometimes they previously might crossing the hand in the midline, they stop doing that. So if you are not really very careful about your developmental history, you would not catch the developmental delay as a result of these devastating seizures. Scenario number 2, also addressing the infantile encephalopathy. This is 4 months, as you can see. It is infantile age, seen in the emergency department for acute unexplained encephalopathy and refractory multifocal seizures. And as you see here, most of my scenarios are in the neonatal and infantile period. I'm talking to focal seizures. There is no evidence of generalized seizure, and I think this is very important take-home message from my side. There is no a generalized seizure during the neonatal and infantile period, because the myelination is not yet completed. So be careful for describing the semiology of neonatal and infantile seizure. So we don't have any generalized seizure in this age. So moving on, the history of this infant given by the parents, which was irrelevant to the clinical condition of the patients. And this is a point that usually indicate the possibility of non-accidental injury. The clinical examination revealed a febrile patient with bulging anterior fontanelle and bruises, and this is more evidence that this patient probably might end with a diagnosis of non-accidental injury. Fundus examination showed some retinal hemorrhage. Also, this is more supportive evidence towards that diagnosis. And CT brain done as an emergency showed that there is frontotemporal subdural hemorrhage, and also this is one of the supportive evidence for the diagnosis of non-accidental injury. And you have to consider other diagnoses before you label your patient as non-accidental injury, because this is a serious diagnosis and need to be addressed very careful. And one of the major conditions that to be put in your differential diagnosis when you see retinal hemorrhage and subdural hemorrhage is glutaric aciduria. And but the glutaric aciduria, they do have different other clinical manifestation, as we said earlier, is macrocephaly. And this patient has rib fractures on skeletal survey, and this is also supporting our thought about non-accidental injury, despite the normal coagulation profile. This is also ruled out the possibility of any coagulopathy that might explain the bruises seen in the examination. This is the classic example of shaken baby syndrome. And usually, if you dig deep in the social history, you might find some evidence that support your diagnosis and a lot of social problems. So history. So this is a retinal, this is fundus examination for the retina. And as you can see, there is extensive hemorrhage in the retina, and this is shaken baby syndrome. Sometimes it might happen when the parents are very excited with the first born baby, and during the playtime they shake the baby, and I think this is the name it comes from there. But most of the time are non-incidental. And this is the CT brain, and you have to have some knowledge about how to interpret the CT brain, especially as an emergency setting, because sometimes you might be the only one doctor in the emergency, and you need to decide, and the time is brain, because any delay might lead to further complication. And this is CT brain. As you can see, there is hypodensity along the cortex, along the left hemisphere, with obliteration and effacement of the ventricular system on the left side. And also you can see there is no white gray matter differentiation. This patient also definitely have massive cerebral edema, and everyone, he can easily detect this CT is definitely abnormal. And also, if you concentrate at the margin here, there is kind of also hyper density here as a margin in the frontotemporal region, which signify subdural hemorrhage. This is important because it will direct your management. So I think that is a common, not common, but scenario has to be considered in the infantile period as a cause for encephalopathy. The third scenario, I try to be a bit faster. Already I'm fast, but I try to finish on time, and at the same time I don't want you to get lost. So this is the third scenario. Also,
you got it till 15 minutes. You can still, you got 15
yeah.
minutes. Okay.
Okay, that is
okay,
fine.
No. Yeah, 15 minutes. Yes.
So this is the third scenario. Also in the addressing the infantile encephalopathy, is a 9-month-old infant with mild developmental delay. Mild developmental delay, which is very important to be just highlighted in red, and no prenatal history of concern, and brought by the parents to the emergency with fever and upper respiratory tract symptoms, and found to be lethargic with axial hypotonia, and the head circumference is 97 percentile, is crossing the centile up and towards the macrocephaly, and he became very irritable with dystonic posture and arching of the back. And already I think we highlighted on this scenario, and this is a classical scenario of glutaric aciduria, and this is a MRI brain of glutaric aciduria, and they call it and describe it as bad twin appearance. And also you can appreciate that there is high signals in the basal ganglia, especially in the globus pallidi, and the deep white sylvian fissure and wide subarachnoid space with some brain atrophy. So when you find such picture, such MRI, and this is basically axial T2 image MRI, which is very showing the structure of the brain very, very nicely. So just try to find out if there is any abnormalities, and you can, as I said, you can see here there is deep sylvian fissures, there is some signals here in the globus pallidi, in the basal ganglia, and also the space here in the frontal lobe simply is wide. And also you can say that there is the global brain atrophy, and this is a classical MRI for glutaric aciduria. And sometimes it's a common question in the OSCE, I think even for the general pediatrics final exam. Moving on to another group of patients, childhood encephalopathies. The etiologies are extensive, and the list is very long, starting from meningitis and encephalitis. Cerebral malaria also is very important to be addressed in Sudan. Specifically during our residency, we saw a lot of patients who present with convulsion and encephalopathy, and sometimes neurological deficit, cerebral edema, and so on. So cerebral malaria is common in our setting, and also diabetic ketoacidosis is complicated with cerebral edema, central diabetes insipidus and SIADA, and especially among newly diagnosed diabetes, because especially for those who live away from the capital or away from the health service. So usually they present late with a DKA complication, and this is top emergency and one of the most common causes of encephalopathy in childhood. Epileptic encephalopathy, we talk about that earlier in the neonatal and infantile period, but in the childhood, you have to consider the commonest ones that frequently seen is Lennox-Gastaut syndrome, and also subclinical seizures, as we said earlier as well, and subclinical seizures also common in neonate and in childhood, specifically among patients with epileptic encephalopathies. Autoimmune encephalitis, very important etiological factors of encephalopathy in childhood, and previously I think in the past, before the advance in knowledge and identifying the autoimmune antibodies, frequently missed as herpes encephalitis or infectious encephalitis. But this is different entities of encephalitis, and it is common and has to be considered, especially if the patient presents with behavioral manifestation and movement disorders and cognitive dysfunction, seizures, and so on. Mitochondrial encephalopathy, every one of you knows that mitochondrial disease, specifically if the patient already known with mitochondria, as they have tendency to get encephalopathic with recurrent infection, specifically, or triggered with infection with seizure or whatever. Any stressors might put them in encephalopathic state. Thiamine and biotin responsive basal ganglia disease, very important to call this, because it is a potentially treatable condition. And if you have patient with encephalitis and you tried everything, the patient not respond and have a characteristic MRI finding, we will gonna see that just now. Bilateral basal ganglia enhancement in the MRI, it might point to thiamine biotin responsive basal ganglia disease. Acute necrotizing encephalitis, and this is usually related to influenza A virus, and influenza A virus is a common virus among population and among children. Demyelinating disorders, very important to be also addressed and considered as a cause of childhood encephalopathies, and it is common. And the commonest one is acute disseminating encephalomyelitis, ADEM. Also, rare causes like progressive neurodegenerative disorders and brain tumors with raised intracranial pressures has to be considered. I think this is 7 years old boy, previously brought with history of flu-like symptoms, and this is just detected in the past history 2 weeks ago. Seen in the emergency for unprovoked status epilepticus. On arrival, found to be encephalopathic with right side hemiparesis and facial palsy. It looks like a stroke, but in fact is not. And treated empirically with as meningoencephalitis, commenced on ceftriaxone and acyclovir as usual, empirically, and had good seizure control in the emergency. CT brain reported normal. That was surprising. Blood film for malaria came negative, and CSF analysis completely normal, but the oligoclonal band it came positive, because they just expect that could be kind of autoimmune encephalitis, or it could be any other kind of demyelinating disease, because the patient, when he arrived to the hospital, he was afebrile, but there was some trigger to the immune system 2 weeks ago, and that might be point to an autoimmune or demyelinating condition. The vital signs showed to be normal at the beginning, but later on started to have some autonomic instability and high blood pressure. No improvement with antibiotic and acyclovir, and the osmolarity and the serum electrolytes reported to be normal. And this is very important during the course of management. You have to be careful looking behind your electrolytes, osmolarity, input, output. All these minor things are very important, to be honest, and it makes a lot of difference in the outcome of the final outcome of the patients with neurological conditions. Brain MRI is strongly indicated at this point, because the patient did not show any improvement, and the MRI, as you can see, it showed bilateral extensive, but I think dominant on the left side mainly, ill-identified, and on the other side is well-identified fluffy lesions indicate in the deep white matter indicate acute disseminating encephalomyelitis, and it is potentially treatable condition with high risk of relapse. But again, if it is treated immediately with immunotherapy, then the patient will recover and get back to the baseline. And definitely after the pulse steroid, you will continue on oral steroid for 6 weeks, and you can read about the details of the management. Other encephalopathies has to be addressed in the area of pediatrics and general pediatrics in general is a hepatic encephalopathy, and the patient have, if the patient have a hepatic dysfunction background or history of hepatic disease. The same idea in uremic encephalopathy, especially among those patients with chronic kidney disease, or sometimes even with acute kidney disease like hemolytic uremic syndrome, sometimes might end with severe kind of renal dysfunction, acute renal dysfunction, high urea, and might end with also encephalopathy. We call it uremic encephalopathy. Hypertensive encephalopathy, also very important among children with renal disorder, and we see them quickly involved in a consultation that the patient with chronic kidney disease have hypertension and then seizures and then become have some visual symptoms and then become encephalopathic. And when they check the blood pressure, they found it very high. And the very important point regarding the management of such cases, you have to be careful on reducing the blood pressure, because if you reduce the blood pressure very quickly, you will compromise the brain perfusion, and the patient will end with ischemic insult and hypoxia to the brain. VB shunt, any patient with VB shunt and present with encephalopathy, you have to make sure that this patient have no VB shunt malfunction or VB shunt obstruction. And usually they present in a lethargic features with variable encephalopathy. But if the encephalopathy in patient with VB shunt, as we highlighted earlier, progress rapidly and the patient become suddenly comatose, you have to consider raised intracranial pressure. And also you have to consider toxic encephalopathy in general, especially among the older children. And sometimes the heterogenic ingestion of some medications might lead to toxic encephalopathies. I think I will skip this scenario because already I discussed it. It's kind of just patient with Lennox-Gastaut syndrome. Is epileptic encephalopathy. Is a patient complain taking the medications.
Ali, you got 5 minutes. You got 3 minutes.
Yeah, that is fine. This is patient of subclinical seizures. So any patient with epilepsy syndrome present with encephalopathy, you have to address, could be part of the course of the condition, and you have to consider the subclinical seizures. This is scenario for VB malfunction or VB shunt obstruction, and with signs of raised ICP, and also is very important to consider in any patient with VB shunt. And this is CT brain showing ballooning ventricles with some signals around the ventricles and edema of the brain and the VB shunt in situ, but definitely this VB shunt is not functioning. That is why the patient present with this feature of massive hydrocephalus, obstructive hydrocephalus. These are the common herniation syndrome. Especially I will concentrate on the last one, which is the cerebellar vermis herniation, and those patients present with decorticate features, decorticate postures, and high blood pressures, and also irregular respiration and brainstem dysfunction. And this is need an urgent neurosurgical intervention. This is a picture for posterior reversible encephalopathy syndrome, and the signals usually just limited to the posterior and occipital lobe. And if it is not treated, they might end with blindness, because this is a visual cortex. Moving on to the cerebellitis, this is a CT to the right and MRI to the left, showing abnormal signals and intensity and density in the CT scan, limited to cerebellum, and this is cerebellitis. And also is an emergency because this is a posterior fossa and they need an urgent decompression, sometimes external ventricular drain and so on. So it is top emergency. And this is also an MRI for herpes simplex encephalitis affecting the temporal lobe. As you can see, the right temporal lobe is swollen. in comparison to the left, and the CT showed hypodensity as well. And this is a classical MRI for limbic encephalitis, which is a form of autoimmune encephalitis. You can appreciate the high signals in the medial aspect of the temporal lobe bilaterally. This is global brain infarct, and when you see such, the only vital survival part of this brain is the cerebellum, but the rest of the brain, the rest of the cerebral hemisphere are kind of swollen and ischemic, and this is when you find such picture, you have to consider drowning or cardiac arrest. And this is a picture for biotin-thiamine responsive basal ganglia disease, and also this is picture for acute necrotizing encephalitis affecting mainly the salami, and this is leukodystrophy. I think this is my last picture, and also you have to address this and consider this important, very important, because commonly also seen in the OSCE exam. And this is a classical example for adrenoleukodystrophy, which is an X-linked condition, also can present with encephalopathy for the disease itself or as a result of adrenal insufficiency. The management approach is very big, starting from ABCs, airway breathing circulation. Such patients sometimes need HDU or ICU admission, neuroprotective measures, normothermia, normoglycemia, and normotension. Anti-seizure medication to control the seizure. Avoid the medications that might give you raised intracranial pressure like ketamine. CT brain definitely after stabilization of the patient. Glasgow Coma Scale, serial Glasgow Coma Scale, and pupil chart, and examination of the rest of the system. And also, if there is signs of raised ICP, consider an urgent referral to neurosurgery, because they might need an urgent surgical intervention. I think the rest of the things, the nutritional and the bladder and bowel care and the physiotherapy, I will concentrate on this because really it makes a lot of difference in the outcome. The investigations has to be directed towards the etiology based on your history, based on your differentials that in your mind. And the very important point, don't proceed for LB before CT brain, especially in encephalopathic patients, because if the brain is swollen and you proceed with LB, they might end with herniation. And I think this is a very important message to be taken home. Febrile encephalopathy, we highlighted on that, and I will not go further on the special investigation. I think I can share with you this presentation later, because it is really very big topic to be completed in 45 minutes. MDT management is very important, multidisciplinary team. With the multidisciplinary team, also the outcome is definitely different. Take-home message, encephalopathy is a broad term characterized by generalized brain dysfunction. Febrile encephalopathy is common among infants. Encephalopathy mimics include post-ictal drowsiness, hypoglycemia, subclinical status. Toxic ingestion is very important to be addressed. Subclinical status, as I said, non-accidental injury, we highlighted on that extensively. Basic knowledge about interpreting the radiological, specifically the CT as a setting of the emergency is mandatory for any pediatrician. And MDT management, and thank you so much.
Okay, thank you very much, Dr. Ali, for your very nice presentation. You highlight a very important common topic in general pediatrics. You highlighted, the treatable cause of encephalopathy is that these guys you have to know. So presume infectious encephalopathy and autoimmune inflammatory demyelinating encephalopathy, and then toxin-induced encephalopathy. So these three panels, Dr. Ali, you highlighted on it because it is treatable, isn't it?
Yes, I agree, Oshi.
Yeah, and then there is, I know the time is insufficient to you to present this very huge topic. And I know, and I admit these guys are fasting today. And yeah, it is a time for fasting now, but just ask you one question. One of our candidates he asking about in ADEM, what is the ideal time to start steroid to achieve good response? This is the first question. Then if you have a time to summarize, the second question they ask, I just want to select certain questions because, I mean, what's the key factor for Wernicke's encephalopathy? I mean, just you can respond to Adam one is better on because it's treatable.
Yeah. So regarding Adam is kind of multi-neurological presentation. Usually, you have to expect it in any febrile patients who have history of upper respiratory tract infection couple of weeks before the neurological symptoms.
Okay.
And usually on their arrival, the patient would be afebrile. And I think the CT might not show you anything, and even the CSF, and the patients sometimes in the first 72 hours, they might not show any improvement. And when you suspect, definitely it is a clinical and radiological diagnosis. And usually the MRI is very useful. And if you have an access to MRI, to do the MRI in the first 72 hours, and you detect the classic radiological findings, then that is the best time to start the IV steroid based on strong evidence. But again, sometimes in a resource limited regions, you might not have an MRI. Sometimes good quality CT along with good history and examination finding and assimilation, then you can able to decide on starting the steroid. But in conclusion, early is better than delay initiating your steroid management.
Yeah, that is amazing, Dr. Ali. It's very nice presentation. So, I mean, we will stop there. Thank you very much, Dr. Ali, for your presentation again. We will stop there, and we will give a short break for like 7 minutes.